Now we'll move on to the anti-migraine drugs. The anti-migraine drugs are serotonin agonists. They're also called triptans. If you look at their names, their generic names, you'll see that they all end in the suffix triptan. These work by stimulating the serotonin receptors in the brain, and they're the first-line drugs for migraine treatment. They need to be used with caution in patients with severe cardiovascular disease, and we'll talk about why in a minute. The ergot alkaloids, ergotamine, dihydroergotamine mesylate, also called migranol, ergotamine tartrate with caffeine or cafragot. These were originally the mainstay of migraine treatment prior to the development of the triptans, and they were actually the first migraine-specific medications to be developed. They're generally recognized as safe and effective, but they've fallen out of favor because of the unpredictable patient response with these, and they have greater adverse events as compared with the triptans. So our ergot derivatives are typically used to treat infrequent, long-standing migraines in patients who have had multiple relapses when using the triptans. So they are a category X, pregnancy category X. So they're absolutely contraindicated in patients with cardiovascular disease, cerebrovascular disease, and patients taking any concomitant medications metabolized by the CYP3A4 pathway, like the protease inhibitors, the azole antifungals, certain macrolides. They're typically found to be less efficacious than the oral sumatriptan in the clinical trials, but rectal ergotamine was found to have superior efficacy to rectal sumatriptan. And these drugs are found in oral, sublingual, and rectal formulations because remember, one of the things with migraines, headaches, is often nausea and vomiting. The ergot alkaloids are also contraindicated when you have impaired renal or hepatic function because the way they work is they cause vasoconstriction. So that brings us to this mechanism of action. The triptans stimulate the 5-HT receptors in the cerebral arteries, causing vasoconstriction and reducing the headache symptoms. So they reduce then also the production of inflammatory neuropeptides. The triptans are what we call abortive therapy, meaning that they treat a migraine that is already started. Ergot alkaloids, same thing. They narrow or constrict the blood vessels in the brain, but they have all historically been used in more of a prophylactic way, or like I said when we have relapses. The triptans actually come in many forms. They can be given IM, they can be given orally, they have a nasal spray. Regardless of the form, they all cause vasoconstriction, and this is cerebral vasoconstriction. So they treat the pain and the nausea of the headache, of the migraine headache. If given IM, we have irritation at the injection site, and sometimes the patient may feel a tingling or flushing because of this vasoconstriction that's occurring. The ergot alkaloids, adverse effects include nausea and vomiting, cold or clammy hands and feet, muscle pain and dizziness. Again, we're causing vasoconstriction. So, when you think about the way these drugs work, this explains why it's contraindicated in cardiovascular disease or peripheral vascular disease or hypertension. We don't want to give drugs that are going to add to the vasoconstriction. Moving on, we get to the analeptics. Now, these medications are used less frequently. They are still used in neonatal apnea, but technically, I want to just say that an analeptic is a central nervous system stimulant. but we don't consider all central nervous system stimulants analeptics. So we kind of reserve this term for those respiratory drugs that are in this classification. These are the drugs that restore the depressed medullary and cerebral function. We see less use of these due to having better options for medications. Our examples are doxapram or Dopram, and then we have the methylxanthines such as aminophylline and theophylline, and of course we have caffeine. Notice that they end in "ine." So our doxapram is used in the treatment of respiratory depression associated with anesthetic drugs, and this is when you will see this medication used is in the clinical setting. Also used when we have respiratory depression with drugs of abuse or COPD-induced hypercapnia. With this medication, the patient needs to have deep tendon reflexes monitored as well as vital signs and heart rhythm to prevent overdose of the drug. So this is a medication that's going to be given in a controlled clinical environment. Caffeine, you know this drug, right? It's found in over-the-counter drugs, combination prescriptions. Excedrin, for example, has different formulations. One of them has acetaminophen, aspirin, and caffeine in it. It's in food and it's in beverages. So we use this medication in caution when we have patients that have a history of peptic ulcer, also with recent myocardial infarction or dysrhythmias. Again, it is an ine, it's an antileptic, and the analeptics still are central nervous system stimulants. How do these work? The analeptics work by stimulating areas of the central nervous system that control respiration. So our methylxanthines inhibit the phosphodiesterase, and that leads to a buildup of the CAMP, the cyclic adenosine monophosphate. The caffeine antagonizes the adenosine receptors. Again, as you're studying these drugs, remember to look at your suffixes. Sometimes that'll help you to figure out what classification it's in and what are like drugs. So what are the adverse effects of the analeptics? Well, they could be vagal effects. So we can have stimulation of gastric secretion. That's from our cranial nerve, our vagus nerve. Diarrhea, reflex tachycardia. Vasomotor, so they may have flushing and sweating. They're going to have an elevated respiratory rate and muscular tension and tremors. Our nursing implications now are for all of the central nervous system stimulants that we've talked about, those both in part 1 and in this audio lecture. Remember, we're going to assess for potential contraindications, potential interactions. Don't forget to ask about herbal therapies. Are there any conditions such as abnormal cardiac rhythms, seizures, palpitation, or liver problems? For children, it's important that we assess baseline height and weight. And when they're on these central nervous system stimulants, we should be getting regular height and weight monitoring more frequently than we would expect in a child who's not taking these medications. Remember, we'll talk about it later, but those will go onto a growth chart and we'll be monitoring that very closely. With the drugs for ADHD, the last daily dose should be given 4 to 6 hours before bedtime to reduce the chance of insomnia. They should be taken on an empty stomach 30 to 45 minutes before meals. Drug holidays are often ordered, although they are starting to fall out of favor because we've gotten good at adjusting doses. We want to instruct the parents to keep a journal to monitor the child's response to the therapy and monitor the child for their growth, their physical growth, their height, their weight. Although it's specifically noted with Strattera, that is not a central nervous system stimulant, just know that the CNS stimulants for ADHD can cause depression and suicidal thoughts even in children. So we want to monitor their mental health as well. With our anorexians, these should never just be given as a single way of treating obesity. The patient needs to be helped to understand that they need to follow the instructions for diet and exercise. This medication is taken in the morning. They should avoid caffeine with it, and they may have to have a fat-soluble vitamin supplement. So since the way that this medication works, it affects those fat stores. With our triptans, we can have, like I said, dissolvable wafers, nasal sprays, self-injectable. One of them even has a subcutaneous form. We want to make sure that we're providing very specific teaching about the proper way to administer these medications, and instruct our patients to keep a journal to monitor their response to therapy. A patient with migraines should be keeping a headache journal, and I encourage any patient who's having headaches that have recently started or that they're not being able to get under control to keep a journal of that, keep a headache journal. With our ergot alkaloids, we want to monitor and make sure that the patient doesn't have chest pain, confusion, slurred speech, vision changes. If they do, then we need immediate medical attention. They need to be taught that. With our analeptics, we have to pay very close attention to the ABCs because the patient has this diminished sensorium with these drugs. We want to continue to monitor all of these drugs for their therapeutic response. So, for example, with ADHD, we would expect to see decreased hyperactivity, increased attention span, and concentration. With our anorexians, we would expect to see appetite control and weight loss. With our narcolepsy, we would see decreased sleepiness. With our migraines, our serotonin agonist, we would expect to see a decrease in the frequency, the duration, and the severity of the migraines. As always, we'll monitor for the adverse effects. You know how to get a hold of me. Email, call, text, send a post. We'll see you soon.